So thank you so much for the invitation. It's my pleasure to talk to you today about ProValf-PCD. And this is very much a BEAT-PCD kind of collaborative study. And I'm presenting the results from this cohort study on behalf of the whole study management team and also all the participants in the study. So we'll be going through the natural variability in lung function, and this is derived from our findings from PROVALF. And PROVALF stands for Prospective Observational Multicentre Study on the Variability of Lung Function in Stable PCD Patients. So let me just see if I can move on to the next slide. Aha. There. Right. So as we all know, PCD is rare, genetically and phenotypically heterogeneous multiciliopathy. We also know that impaired mucociliary clearance leads to chronic respiratory disease, recurrent infections that can lead then to bronchiectasis and progressive lung function decline. We also know that FEV1 derived from spirometry is the most commonly used outcome measure to monitor lung disease in PCD, both in clinical care and in research settings. In research, it's used in observational studies, including prospective cohorts, but also now more commonly used as a primary outcome measure in recent clinical trials. In fact, spirometry was one of the four core outcome set measures that were recommended from the BEAT-PCD consensus statement on core outcome sets to be used in every pulmonary intervention trial in PCD. And just for reference, the other three were health-related quality of life scores, microbiology, and pulmonary exacerbations. But in spite of this, we know relatively little about the short-term natural variability of FEV1 in clinically stable patients with PCD. But why does short-term natural variability matter anyway? In clinical practice, for example, when you're seeing a patient that has a drop in FEV1, let's say by 5 or 10% of FEV1% predicted, it's often hard to say when this drop actually reflects normal day-to-day variability or is something that's clinically important, like a pulmonary exacerbation episode or signs of early disease progression. So being able to distinguish between those two possibilities is very important. And for designs of clinical trials, on the other hand, it's important for sample size and power calculations, and also for definitions of response and non-response to treatment, because all of these factors depend on assumptions about within subject variability, which is what we're going to discuss today. It's also important to understand whether we can rely on FEV1 as a primary endpoint for randomized controlled trials, especially as now there are more and more randomized controlled trials being developed and conducted in PCD. We know from CF that a few studies found that there is day-to-day variability in FEV1 when measured using, for example, home spirometry, and these variability are commonly found, and within subject variability can be as high as 16% in these studies. So I'm going to come back to this number after we talk about the numbers in PCD, so keep that 16% in mind. But while we know in PCD a little bit about long-term function decline, and there have been many BEAT-PCD studies, large multi-center longitudinal studies looking at lung function decline in PCD. We know less about this short-term variability, and this could be daily variability, for example, in patients that are stable, so not experiencing an episode of exacerbation. So the aim of our study was to then quantify the natural variability and determine how much change in FEV1 is needed before we can say that this change actually reflects a real clinical change. So the design of the study was a prospective observational multicenter cohort study, as it says on the study kind of title, and it was conducted between August 2017 to December 2019. And it was conducted in 19 PCD centers in 12 countries. The definition of clinical stability was not having a clinician-defined exacerbation. So this is important, and it's important to note as well that ProValf-PCD predated the BEAT-PCD consensus statement. on the definition of pulmonary exacerbation in patients with PCD. So this statement was published in 2019 and the study started in 2017. So the criteria that we use, the clinician defined exacerbation, is slightly different from the criteria that's used in the study. And I'll come back to this. But just for reference, the pulmonary exacerbation definition consensus statement says that you have to have at least 3 of the following. And that was increased cough, change in sputum volume or color, increased shortness of breath, decision to start antibiotic treatment because the clinician thinks that the patient is experiencing a pulmonary exacerbation, tiredness or fatigue, new or increased hemoptysis, or the presence of fever. So none of this definition include actually spirometry measurements or FEV1 derived from spirometry. In terms of the inclusion criteria, all participants that were 5 years old or older were eligible to be included in the study. They had to have either a confirmed or a highly likely PCD diagnosis, and this was based on the previous, so not the most recent ERS-ATS joint kind of diagnostic guidelines, but the previous version of the ERS diagnostic guidelines. They had to have at least 2 consecutive visits where the patient was in stable state, so not experiencing a clinician-defined exacerbation. And also they had to have visits at least 6 months apart from each other. So if they had more or less frequent visits, they weren't eligible to be included. In terms of the visit schedule, there was routine follow-up visits that were conducted where we collected data on spirometry, and these had to be reproducible spirometry measures according to the ERS-ATS standards. Also collected data on symptoms and the standard clinical assessment and any treatment changes. We had the initial kind of baseline visit where we collected additional data on diagnostics and demographics of the patients as well as clinical history. Participants could also contribute with additional tests that had been performed, but the main outcome was spirometry derived measurements. FEV1 was collected as a raw value, and then we used the demographics and other clinical information to convert these to Z-scores using GLI reference equations. So in terms of the statistical approach, the main outcome for our study was within subject variability of FEV1 in clinically stable PCD patients. So this is how much the FEV1 actually fluctuates around the individual's true value. We modeled this using repeated measures and then used a linear mixed effects model with random intercept for individuals to separate between subject and within subject variance, which sounds very complicated, but really isn't. So what do I mean by repeated measures? It just means that each person had more than one lung function test per patient. So instead of having one lung function, we had multiple, and that's the longitudinal kind of approach to this. And then the random intercept is because some people naturally have higher or lower lung function at start. So the random intercept is just a way to statistically account for that and allow each person to have their own starting point. So some might start at a higher FEV1 value, for example, and some at a lower value. And this type of modeling allows for that, as opposed to just pretending that everyone starts at the same lung function level. And then more importantly, the model separates 2 kinds of variance. So first we have the between subject variance, and then we have the within subject variance. So if you look at the between subject variance, this is the difference between patients. So for example, if you look at the schematic, we have person A that has, say, an FEV1 of around 90% predicted. Person B has an FEV1 of, say, around 65% predicted, and C has about 75% predicted. So this difference between people is one of the components that varies. So there's the variance between 90 to 65 to 75. But then we also have the within subject variance. So this is the natural fluctuation within the same person over time. And that's what we were actually interested in this study, because we want to see how FEV1 fluctuates over time within a person. So person A might have 90% FEV1 percent predicted at their first visit, and then 88 at the subsequent, and then 92. And this wiggle within that same person from 88 to 92 is what we're measuring and interested in this study. So why does this matter? We need to separate these two types of variation so we can tell if FEV1 is just a normal day-to-day fluctuation or a real sign of improvement or deterioration, depending in which direction it's going. And this method gives us an estimate of the true biological variability for each person, and that's not muddied by the differences between individuals. We're only interested within. So once we know the typical noise level for stable PCD patients, and by noise level, I mean what is expected within the variability. Did I just, yes, I did. Okay, sorry. What is expected within this variability. So that's likely what we can call noise, but also we can call the test variability. So the variability of spirometry or FEV1 to detect any changes. And then anything beyond this variability is more likely to be a real deterioration or improvement in lung function, and therefore clinically meaningful. And that's what we're interested in, separating those two. So this is, I'm just explaining this briefly because this is the basis for calculating the coefficient of repeatability, which is just basically talking about how reliable the test is, but I'm not going to go too much into that today because it's a bit more technical and less useful in a clinical setting, I guess. But it's also the basis for defining the upper limit of normality, and that's what we're going to focus today on because it's a bit more clinically translatable. So for our study outcome, as I mentioned, we wanted to know how large does a change in FEV1 need to be so that we can say this is a real change and not just a normal fluctuation or normal variability. And to do this, we only use measurements in patients that were stable to allow us to measure natural variability. And we then calculated a relative change. So this is basically how much an individual's FEV1 goes up and down between two stable visits, expressed as a percentage. So it's the percentage of the change compared to the previous measurement. So it's important to keep that in mind, and I'll provide some examples. But we calculated this for the entire cohort to obtain a distribution of how much FEV1 varies, and particularly when it varies when nothing else significant is happening, meaning they're not having an exacerbation, they're in stable state. But we also calculated this for each individual patient. So I'll show data for both of those cases. So we use these calculations to then obtain what we call the upper limit of normality of the test. So this is the level above which changes are unlikely to be at random or due to kind of test variability, which this so-called noise, I guess. And this allowed us to say that if there's a drop in FEV1 that's greater than this upper limit of normality, then this drop in FEV1 is unlikely to be simply due to natural variability alone or the test variability. Another thing that we were interested in looking is what determines the variability we're observing. So why do people with lung function, some people fluctuate more than others? Is there something that dictates this fluctuation even when they're all in a stable state? So we looked at certain factors like sex, type of ciliary ultrastructural defect by transmission electron microscopy, presence of respiratory pathogens, and baseline lung function to see if these are linked to how much a person's variability or FEV1 changes naturally. So I'll talk about this as well and provide results from these. We also did a few subgroup and sensitivity analysis to check if our findings were robust. So subgroup analysis includes stratifying our results by age group. So we look at just a group of children and just a group of adults and compare those to see what is the variability in each of these subgroups. We also looked at the impact of having more than 2 measurements of FEV1 per participant. So if you remember the inclusion criteria, we needed at least 2 measurements of FEV1 per patient in a stable state, but some of these could have 3, 4, 5 measurements per patient. So we did sensitivity analysis, restricting our analysis to only those that had at least 3 measurements or more of FEV1 in stable state. And then also did another sensitivity analysis looking at those that had at least 4 measurements or more in stable state during the study period to check if that made any difference to our findings. We also looked at whether the time between visits makes a difference, because we know from other studies in other diseases that sometimes if you increase that time between visits, so say a patient comes every 3 months or a patient comes every 6 months, that might increase the variability if you're looking at these longer periods between visits, so 6 months. So we also restricted our analysis to only measurements that happened between 4 months or less to see if the variability increased if we include those that had less frequent measurements. So what did we find? So in the end, we ended up including 252 participants. These were from 19 PCD centers in 12 countries. We have a breakdown of the countries and the number of participants in the table to the right. But in terms of measurements, individual lung function measurements collected, we had over 1,100 measurements of lung function, and just over 1,000 of those were in stable states. So 87% of our measurements were during stability or patients not experiencing an exacerbation. We had 419 of those measurements from 84 adults, and we had 759 of those measurements from 168 children. So we had double the amount of children that we had adults in the study, and that's important as well to keep in mind. But if you look at the table from those 252, a lot of the participants came from England, Germany, Turkey, and Spain. But we also have at the far right the median number of visits per patients. So in total, the median number was 3 visits per patients that we had, and the interquarter range varied from 2 to 4 visits per patient. But this varied as well between countries, with some countries having patients having up to 10 visits during the study period. And just as a reminder, the study period was about 18 months. Oh, there you go. And then in terms of the diagnostics, 72% of the participants were classified as confirmed PCD based on TM or genetics and genetics as well, the combination. So these are represented here in blue and green in the Venn diagram. And that was the majority of patients. So they did have confirmed PCD according to the old ERS evidence-based diagnostic guidelines. Of all the cohort, about half of them had abnormal TEM and an abnormal ultrastructure by TEM, and 45% had biallelic mutations in PCD causative genes by genetic testing. The remainder of the patients had a combination of clinical history that's suggestive of PCD, nasal nitric oxide testing, and high-speed video analysis as well. And then looking at the individual trajectory of FEV1 within each of these patients, we have here a figure that shows the breakdown per country. So each of these dots represented in the figure is an individual measurement, and then the line connects 2 measurements from the same patients. So you can see the trajectory of the lung function in these patients. The x-axis is the time in months from baseline, and baseline is their first visit. And then the y-axis is basically the FEV1 Z scores. So you can see that a lot of them are below the 0 kind of Z score. So they already have a low FEV1 Z score to begin with. But we wanted to check this because we wanted to see if there were any patterns that we could identify per country, because country is one way that the data were clustered, and there might be differences between treatments or management strategies in different countries. But what we can see here is that there wasn't any pattern that was evident, and there were large variations within a country as well. So some patients doing very well, some patients doing very poorly, and trajectories that remain constant in terms of lung function or increased or decreased. So there wasn't anything that we could spot, but we also did analysis stratifying or clustering by countries, adjusting for that to check if that was the case. And these differences that we see here could reflect a numerous amount of factors, and that could be just disease heterogeneity that we know is very high in PCD, but it also could reflect underlying genetic profile of different populations as well. We know that there are genes that are predominant in different populations. So in terms of our main results, we found that that upper limit of normality between two measurements of FEV1 was 25% in stable patients. So what this means is that only changes that are higher or beyond this 25% threshold, and as a reminder, this is 25% relative to the previous measurement. So any changes that are higher than this can be confidently interpreted as a real change rather than natural variability. And this is a very high kind of threshold for this. So it's interesting to kind of note that this is possibly higher than many clinicians intuitively use in clinical practice to say if a patient is stable or not. Because a drop of 25% in FEV1, for example, is quite striking. And then when we divide it, and I'll come back to this a little bit when we talk about what is the interpretation of this and what is the clinical meaning of this. But it's also important to keep in mind that these relative changes are, as I mentioned, relative to a previous appointment. So an example would be a patient with 40% predicted in his first baseline appointment, let's say, and then a drop of 25% for the second visit or the subsequent visit would mean an FEV1 of 30% predicted. So that's what that difference would represent of 25% drop. While in a patient that has preserved lung function, say 100%, that drop would be 75% predicted in the subsequent visit. So it's important to keep in mind that this is a relative measure. In our subgroup analysis, the upper limit of normality was 25% for children, versus 20.5% for adults. And also keep in mind that the majority of our participants were children. It's a 2-to-1 ratio, basically. So that 27% possibly drove a little bit the 25%, but it's still very high for adults as well, because 20% is a big kind of change in a relative change in FEV1. Also, another thing that was interesting is we looked at the participants that were only having an exacerbation. So we took those measurements while they were in exacerbation and also calculated the upper limit of normality for that. And we saw that that was 29%, which was just marginally higher than the upper limit of normality that we observed for patients in stable state, which is 25. So that's quite interesting and could suggest that FEV1 derived from spirometry is not really discriminatory to tell when a patient is experiencing an episode of exacerbation. That said, it's important to remember that most of our patients or most of the measurements we used in the study were collected during stable state. So the amount of measurements that we used for this calculation of the pulmonary exacerbation upper limit of normality is very restricted. It's a small sample, so we shouldn't focus too much on that. As I mentioned, we also looked at the individual kind of relative change, and this varied between 1% and 81%, which is quite a large range. So if we look at the figure here, that horizontal line that's pointed here shows the upper limit of normality for patients in stable state. That's the 25% threshold. And the x-axis, we have individual patients. So you can see that there's quite a big amount of patients that lie kind of to the above that, the patients to the right, they're above that threshold of 25%, even though they were all measurements taken in stable or clinician-defined stable state. So that's quite interesting to see as well. But when we looked at this information, what that means is that when looking at just the proportion of patients or the subset of patients that had a relative change above 40%, so those very much on the far right, there were only 22 patients in this, or participants in this area. And of those, 15 were actually an increase in FEV1. So it was an increase in 40% compared to the previous visit. So an improvement and not actually a decrease in FEV1. There were 7 participants, though, that these 40% changes represented a decrease in FEV1, and that varied between 43 and 77%. So that's quite a big decrease that was seen for some participants still considered in stable state. In terms of the determinants of variability, so what we did to look at what could be influencing this variability, if there's any particular characteristic that determines that variability will be higher or lower in a subset of individuals. So here we have a figure that shows the coefficient of this regression model. So we looked at all these characteristics together to see how much they explain the variability observed. And you can see the whiskers to the sides of these individual estimates, which are the dots, or the confidence interval. So keeping that in mind, if we look at the females, for example, so we found that women had slightly lower fluctuation in FEV1 compared to men. We also saw that patients with central pair defect on transmission electron microscopy seem to have smaller changes between visits as well. And this, or a smaller fluctuation in FEV1. But it's important to note that the confidence interval is quite large for these, and this is because we have very few patients that actually had a central pair defect on TEM. So you have to take that into account. These estimates are not really precise, and they're very small changes as well that we're seeing. The one determinant that seemed to explain the majority of the variability of what we could explain was actually the baseline FEV1 value. So patients with a lower FEV1 to start with had smaller changes between visits. So this means that if the patient's lung function was already low, it remained stable, basically. And that's possibly because there was less room to move down. It already started from an initial value that was low. However, one of the important things to say here is that all these factors that we looked at, only explained about 20% of the variability that we observed. So the source of most of this variability remains unknown and isn't explained by any of these factors. Before I go into the strengths and limitations, I mentioned the sensitivity analysis before. So none of the sensitivity analysis that we conducted actually changed the results. So having 3 or more visits didn't change the upper limit of normality. It was basically 24% as opposed to 25. The same one we restricted to having at least 4 measurements, and the same one we restricted to having a smaller time interval between measurements. Nothing really made much of a difference, and that just confirmed that our results were robust, and it didn't matter too much if we had many visits or if we had visits that were closer together in the end. So in terms of the strains, This was a prospective multi-center design, as I mentioned, conducted in 12 different countries and 19 PCD centers within those countries. And this in general reduces bias and also enhances the generalizability across PCD centers. We didn't just conduct it in one location. And as I mentioned and shown in the figure with all the different plots of the trajectories of the patients, this just means that these findings are probably applicable in various settings. We also use a standardized data collection to record each appointment data across all the different centers. So even though we didn't have study-specific visits, which might be a limitation, all the data was collected routinely at their routine clinical appointment, but we did use the standardized data collection with clearly defined variables. So this minimized variability in terms of the data that was collected across the different centers and countries. We focused only on patients who were clinically stable for a main analysis, and this was defined as not having a clinician-diagnosed pulmonary exacerbation, as I mentioned. So this is both a strength and a limitation. I guess the strength is that clinician defined is what normally guides clinical practice and initiation of treatment for pulmonary exacerbation. It's basically what the clinician judges based on their clinical knowledge if the patient is experiencing an exacerbation or not. And this is what usually they take into account all the different objective measures as well as what the symptoms the patients were telling them and what they're seeing to make a judgment if that patient requires antibiotic medication, for example, initiation of treatment. But it's also a limitation because we know that clinician defined could be different based on different clinicians. So it is a clinical judgment and different clinicians might judge it differently. And it might also differ between countries. So what might be considered as stable might not be consistent across all the different countries. So that's also something that could lead to one of the limitations that I've mentioned here. So misclassification. So clinician-defined exacerbation might have been misclassified as stable when they were actually experiencing exacerbation. But I guess more likely, clinicians might consider a drop in FEV1 as a sign of pulmonary exacerbation. So larger drops in FEV1 would likely mean that these patients ended up being classified as having an exacerbation as opposed to the other. So the misclassification is probably more likely going in that direction, which means that for a main analysis, these misclassifications would have not been included. They would have been excluded as we're just using clinician-defined patient measurements that were conducted during stable periods for the main analysis. But if we had applied the consensus definition, for example, which doesn't take into account directly spirometry, it does indirectly with initiation of treatment, I guess, and that one of the factors might be if you see a massive drop in FEV1 at the clinic visit and the patient's not looking too well, you might initiate treatment, and that is captured by the consensus statement. But the results might have been different if we had captured all the variables within the consensus statement that defines pulmonary exacerbation, and would have been good to have been able to compare that to the clinician-defined exacerbation as well. And that's a limitation of this study. As I mentioned, the pulmonary consensus statement was published in 2019, so we had already started and were collecting data for this before then. And lastly, from the diagnostic breakdown of the patients included in the study that I showed before in that Venn diagram, I also mentioned that only 45% of the participants in the study had a genetically confirmed diagnosis of PCD. This is probably a reflection of the times. So now it's very routine to have genetic testing available for PCD patients, and a lot of the centers do this for all the patients and have genotyping information. But at the time in 2017, when the study started, up to 2019, when we ended ProValf, it wasn't as common and it wasn't as widespread as it is now. But as I mentioned, over 70% of the participants had either a TEM or a genetic diagnosis. So the majority had a confirmed PCD case, but those that were just highly likely PCD, there might be some misclassification in that as well, and some participants might have not had PCD. So it's important to keep that in mind as a potential limitation as well. So what does this actually mean in terms of clinical implications and implications for future research? So for day-to-day clinical care, how should one interpret a single drop in FEV1? So I think what we can take from this is that small isolated drops in FEV1 within that 25% relative change threshold in an otherwise well patient should be interpreted with caution. So it might be that some of those drops are reflective of just the test variability or that noise that we mentioned, or just within subject variability. So all of these are a potential cause of changes that we can see in FEV1 that don't really mean there's anything clinically meaningful going on. But repeated changes or drops in the same direction, for example, or changes exceeding this threshold are more likely to represent true disease progression or exacerbation. This also means that something that we empirically knew, and there were studies that showed and compared FEV1 with other types of lung functioning measurements, such as multiple breath washouts, and that's that spirometry is not really good at detecting small changes or early changes. And we might only be able to detect these changes when they're already large. So that's a massive limitation of just using spirometry in clinical practice. And I'll talk a little bit about this as well in the next slide. But for clinical trial design and endpoints, a selection of endpoints, our findings also have implications because how we design and run clinical trials in PCD, especially trials testing new drugs, aim at improving lung function and slowing disease progression. We need to know the within subject variability. And the reason for this, I mentioned at the beginning, we need this information to take this information into account for example, sample size calculations or to determine what we are going to classify as a response or a non-response to drug. But also randomized control trials often use FEV1 as their primary outcome. So they'll need this to calculate the sample size, but also we have seen here that there's a high natural variability of FEV1 from the study. So small treatment effects may be missed, and clinical trials using FEV1 as primary outcome measures may appear to be negative or show no benefit when in fact the drug has a real but small or I say small, but it doesn't even have to be that small. We're talking 25% here. So a modest kind of benefit in lung function improvement, and that might not be captured because it's lost within the test's variability or that noise that we've seen. So what we really need moving forward is more sensitive outcome measures, particularly for research. So lung clearance index, for example, derived from multiple breath washouts, seems to be better at detecting subtle changes in PCD compared to FEV1 derived from spirometry. And there are studies in PCD looking at lung function clearance, but we don't know yet the upper limit of normality in PCD. We do, however, have data from CF. And from CF, what we know is that LCI has a variability of 10% reported in this study that I mentioned down here. So it seems to be more sensitive than that 16% that I mentioned at the start, which is derived from spirometry, FEV1 measured by spirometry. Oh, back to this one. Okay, so in conclusion, what we showed in the study is that only very large changes in FEV1, and when I say large, these are over 25% relative changes in FEV1 compared to the previous visit, can be confidentially interpreted as real changes. rather than just normal test variability in stable PCD patients. Smaller changes might simply reflect the natural noise of spirometry, so the reliability of the tests or the variation of the test. However, it's very important to say that FEV1 is not really used in isolation and shouldn't be interpreted in isolation, especially in clinical practice. Clinical judgment remains essential, and depending on patient symptoms, history, overall condition, even when these changes are small, statistically, they might be meaningful. And statistically large changes might not be meaningful. So interpreting spirometry results in light of clinical knowledge and judgment is very important. When we talk about these findings are really kind of informative for a research setting, and we talk about what is statistically different or not. But again, statistical difference doesn't necessarily mean clinical difference, and it's important to kind of separate those. These findings also have important implication and potentially even greater implication for current and future clinical trials in PCD. As I mentioned, FEV1 is relatively insensitive, derived from the findings of the study, to detect early and modest changes in lung function. So relying on it alone risks missing true treatment effects. More sensitive outcome measures. So I mentioned LCI, but there's also high-resolution CT scans to look at the structure of the lungs. There's also functional and structural MRI. And these should be considered when designing pulmonary intervention studies and evaluating new drug therapies as well, because we wouldn't want to miss the true effect just because spirometry and FEV1 measurements are not sensitive enough to actually show that there is a benefit in the lung function due to the treatment. So I just wanted to give my acknowledgments to the study management group. So this study would not have been able to be conducted without Jane, Philip, Nicole, and Claudia, who were present from the conception of the study all the way to interpreting the analysis and providing feedback on the manuscript as well. I also wanted to thank Kawei and Bettina. They both led the data analysis. Kawei did all the data analysis for this with the guidance of Bettina, who had done similar kind of statistical analysis in CF. Also want to thank the CTU and Bern for their support using REDCap, which was the study-specific platform that we use for data entry. All the PCD centers that participated in the study, as well as all the study participants who contributed with their data. This was very much a BEAT-PCD collaborative study. And you can see from the publications here that I have on the right, the top one is the one that I'm talking about today, the natural variability, but we also published a cross-sectional looking at the association between respiratory pathogens and lung function using data from the PROVALF study, and it's very much a BEAT-PCD collaborative study. In fact, the study started back in 2015 when I was starting my PhD here in Southampton. We had the first BEAT-PCD conference here, and that's when the idea for PROVALF actually started, and was Philip that was interested in this, came up with the name, and we kind of started putting together the study management group, and it took off from then. And throughout the data collection up to 2019, we were already kind of finalizing that first version of BEAT-PCD, but it was very much a joint effort by everyone involved, and all the PCD centers that participated are members of BEAT-PCD as well. And I just wanted to thank as well the NIHR Southampton BRC here, because they funded me to finish the study. So I came back to Southampton on a bridging fellowship funded by them in order to kind of wrap up these two studies, findings from the studies. And thank you very much for listening. I'm very happy to take any questions.
Wonderful presentation, Bruna. Thank you very much to
I will
those
just stop sharing.
Yes, sure.
There you go.
with those surprising large ranges among individuals. Let's look at some questions. We start with Mina. She's asking, would performing airway clearance before spirometry improve reliability of the results?
Yes, so we recorded the time of the physiotherapy in clinics as well. So we have that information, and the majority of the spirometry measures were conducted after physiotherapy. So there was some clearing of the lungs, but this obviously varied between centers. So if we were to conduct this as a prospective kind of study, specific visits, um, funded project, we would have just have that as a standard across all the different centers so that we could collect the data after they've done physiotherapy. We recorded both physiotherapy at clinics and physiotherapy at home as well. So I guess this is also potentially the time to say that there's quite a lot of data that we collected in ProValf. So if anyone is interested in doing any secondary data analysis, we have plenty of data on physiotherapy techniques, the timing of physiotherapy. Some centers provided spirometry before and after physiotherapy, and also before and after bronchodilator. If they did, we use the pre-bronchodilator data and we use the after physio data for this study. But there's more additional information if anyone's interested in looking into those as a secondary data analysis as well.
That's great. I was also wondering about that, about the airway clearance technique among in different centers or also among individuals. If you had any data, if they do physiotherapy by themselves or both by themselves, and also see specialists, so physiotherapists. So that'll be very interesting to look into. The next question is from Mine.
Yes. Thank you, Bruna. Excellent presentation. I wonder that you observed slightly lower variability in patients with central pair defects. Given the known genotype-phenotype differences in PCD, did you observe whether natural variability patterns differ according to the genotype?
So that's a great question. We didn't have genetic information on that. So the study started in 2017. It was still that start of genetic testing being a bit more widespread. And because we had to obtain ethical approval to do the study, even though it's routinely collected data, it still had to go through all the ethics in each of these countries. We just felt that we wouldn't go through the additional step of getting ethics to share genetic data at that time. So we are unable to look at that in particular, but I suspect that some of the defects will be reflecting the underlying gene condition. What I will say about the central pair, I mentioned small sample sizes for that, and we only actually had 6 patients that had central pair defects. So even if we, particularly if we had the genetic information, we still wouldn't be able to make a lot of conclusions based on that due to the small sample that we had.
Great. Thank you, Bruna. The next question is from Lucy. In the UK, many patients have home spirometers for ongoing monitoring. They may be prompted by the medical team to submit a measurement, or they may self-manage and monitor when they feel like it. The anticipated advantage is that it provides more data points, as many people may not be seen especially frequently, and that it allows for better home monitoring. Do you think home monitoring of FEV1 is problematic in light of this study?
So what I would say is from other studies, there seems to be more variability even seen from home monitoring and home-derived spirometry measurements. We did not look at this in ProValf in particular. We were just using clinic kind of physiotherapy-led measurements or clinician led. In the UK, it's basically physiotherapy led. who are trained and do this routinely. But it would be interesting, I think, to check if home spirometry has higher variability in PCD, which I suspect it does. But what I will say in terms, and I think I kind of get this every time I present something related to ProValf and the results, I get this question about should we even use then spirometry in clinical practice? And I think spirometry is the only test that's available everywhere to measure lung function. It's cheap, it's easy to perform, it's easy to interpret. There's standardized guidance on how to do it and how to report it according to the ETS-URS kind of clinical guidelines. So I think it still has very much its applicability. It's just with ProValf, I guess what we wanted to highlight is that it shouldn't be something that's over relied on, I guess. And I don't, that said, I don't think it is at all in clinics, but it shouldn't be particularly in research if we're planning things to just use this as the only outcome. And granted, I'm aware that this is one of the core outcome sets, and it reflects the wide availability and wide use of spirometry. It's not everyone that has availability to do multiple breath washouts, for example, to look at LCI or to do CT scans regularly. There's also the risk of radiation, and then MRI, there's issues with that in terms of the technique. So I think there's limitations in every one of these measures. So I think it's still useful, and having, as Lucy said, more data points, even for the clinicians, I believe it would, and clinicians can say better, answer this bit better than I can, but will probably be more informative than having less, even in light of the variability and being able to look and say, actually, this could be just variability, but it is one more information or one more data point that they can take into account when they think about how to manage the patient clinically.
Great, excellent. Thank you. And the other question from Mina, could airway hyperreactivity be contributing to the observed fluctuation in lung function?
Could you repeat that? Could airway variability?
Airway hyperreactivity be
Oh,
hyperreactivity be
Mm.
contributing to the observed fluctuation in lung function?
Well, it could. I guess it could. We didn't look at that, but we do have that subset that we looked at, response to bronchodilators, for example. It could be a contributor factor, but the majority of the centers didn't really do that. So it was very common in some countries and very uncommon in others to check that if there was any hyperreaction, that could be taken into account. So we didn't really do a separate analysis for that. I mentioned as well that one of the things that we collected additional test results. So we have a subset of patients from specific centers that we actually have, for example, results of multiple breath washouts, and we have CT scan results, reports, etc. But those numbers were too small for us to look at. It could be the basis of a larger study that someone could have a look and kind of plan around it. But we didn't feel like we would have sufficient numbers to even check if that was the case because of the amount of patients' data that we had for those.
Great. Thank you, Bruna. I have a question about the BMI. Since you adjusted for that as well, I was wondering if you noticed any drastic weight fluctuations regarding with even changes of BMI categories, which maybe could also explain those variability in lung function.
So yeah, as you mentioned, we did adjust for BMI in our models. especially the longitudinal model. So I didn't present here, but we also looked at lung function progression throughout and found that our results were similar in this between patients, how much it kind of decreased between patients. And our results were similar to what's been previously published in the literature. We had difficulty in classifying BMI as well because we wanted to use Z scores, and that's not necessarily available throughout. So it was difficult to even categorize this, and we didn't particularly then, because that was one of the reasons we didn't particularly look at if this was a factor. But when looking at the longitudinal models, BMI was a contributing statistically significant factor, as was the addition of age, and also, as I mentioned, the lung function at baseline as well. But we didn't particularly look at it, Yingting, to kind of see if this varied because of we had to use different ways of calculating and assuming that everyone above 19 was actually at the age of 19. So there was to calculate the Z score. So it was a bit difficult, I think, to compare across because of the use of different metrics.
Okay, I see. Thank you.
you.
And one more question from me. You mentioned that you excluded pulmonary exacerbations defined by a clinician at visit. I was wondering if you had any data about the latest pulmonary exacerbation prior to visit. For example, if there were any exacerbations just 2 weeks or 4 weeks prior, and if you had them, did you exclude them as well?
So we didn't. If the measurement was done when the clinician at the time defined the patient as not having an exacerbation, we included as a stable measurement, but we did collect data on the number of exacerbations they had between visits. So our main model, and when we look cross-sectionally to look at the association between pathogens and lung function as well, we adjusted our models for the number of exacerbations they had between visits, as that could be an indication of having maybe a decrease in lung function overall due to deterioration of disease. So we did look at that, but and that was looked at the longitudinal models basically. And it was a factor that was important. But we also, looking at the longitudinal, the cross-sectional models, we also looked at the fact that the number of exacerbations could be a collider in the relationship and not so much a confounder. So we did a sensitivity analysis without that as well, to check if actually exacerbations was not connected to both exposure and outcome in the pathogen lung function kind of association.
Great, excellent. Thank you very much. Right now, it seems like you answered all of our questions.
Perfect.
That was a wonderful presentation, a very interesting one that really questions the use of everyone that we've had so far in all the trials and observational studies. We know, of course, it's not capturing the lung function at visits and also longitudinally as well, but that's what, of course, most centers do, and it's the most convenient and easy to do measurement still. So we'll see what the future what will bring us all in managing and observing and all of that. So thank you very much, Bruna.
Thank you so much for the invite. It's a pleasure to share the results. As I mentioned, this was a very collaborative BEAT-PCD project, and I'm just here on behalf of everyone who participated in the study just to share our results.